checking in for Supervision Sundays. There are 2 questions that I want to focus on for the purpose of this first session, and that is the initial session enough time to establish a diagnosis? And the second question being, when you find that the client has multiple diagnoses in the clinical chart, how do you discern which one is the right diagnosis? And so just to kind of focus a little bit on this first question about the initial session, from my community mental health background, I know that you can work for agencies who really only give you about an hour to do a biopsychosocial assessment. And so I find that I have struggled in the past, and that a lot of clinicians struggle in really understanding how to diagnose someone in that short a time frame. And so this is what I'll say to that. The initial session is enough time to give a provisional diagnosis. And so what I mean by provisional is that based on the information that has been provided to you in that initial session, you can absolutely establish a diagnosis. However, that diagnosis, as a clinician, you have an obligation to come back and relook at that diagnosis and consistently gather information throughout the other sessions. And so in supervision that I do with my various interns, I always encourage them to say, okay, well, this is the diagnosis that you've established for your client, and you should constantly be gathering evidence to support that diagnosis as you're seeing them, or to say, okay, this diagnosis is not applicable anymore, and this is a more appropriate diagnosis. The DSM is really there to put a name and kind of cluster symptoms together so that we know what's going on. It's also very beneficial for us in guiding our treatment interventions. And so if you cannot establish a diagnosis with someone, then you can't really provide effective treatment because we haven't really said this is what's going on. And then, I know that some people are not a fan of diagnosing in general. And so I think that also plays a part in how we diagnose and whether or not we're willing to diagnose. And so there's a published study in 2009 that really looked at social workers. And what that study found is that for social workers, only about 50% would give their client a diagnosis if they were not required to do so, right? So insurance companies require us to do so for billing. If you work for an agency, they require, your auditors require, but in private practice, depending on whether or not you bill insurance companies, you may not be as required as someone who works for an agency to document and establish everything that you're doing. It's certainly highly encouraged because that keeps the integrity of your practice, but not all people who work in private practice document and do clinical charts and write up treatment plans. I always encourage it. Just because it keeps us on track. It holds us accountable to our clients. And so in that initial session, what's also important to do is to make sure that you consider what the client is telling you, right? And so that kind of goes into this next question as to, you are presented with someone who has a very complicated clinical picture. Maybe in the chart it says that they have multiple diagnoses. Maybe they've been diagnosed with major depressive disorder, bipolar disorder, maybe a personality disorder, and you're trying to really figure out, is this one right or is that one right? And so what I usually encourage my interns to do, and what I found very beneficial for me as I practice, is to really diagnose based off of what you can see in that moment, right? So today, as I'm seeing the client, what symptoms are present? And that doesn't mean that when I go in, I write up that the client has this, this, and this. What you can do is in the interpretive summary, you can indicate that the client reports a history of having various diagnoses and list those. However, in that same interpretive summary, you want to make sure that you say, based on the current symptoms, and based on the available data at this time, there is enough information to establish this diagnosis. So we're not taking away from that clinical history that the client is reporting. We're not taking away from the clinical history that may be in the chart from maybe a couple years ago or even 6 months ago. What we are doing is saying that based on this assessment, this is the available data and sources of information that I have, whether it be client report, whether it be a copy of a psychiatric evaluation, maybe it's court documents, something that the client has brought in, but based on what is present right now, this is what I can establish as an effective diagnosis. And so you also want to make sure that you go into that clinical chart, and if it's a diagnosis that is from years ago, you can expire those, but you want to justify why you're doing that in your interpretive summary, so that when you're doing your treatment plan, it's very clear the diagnoses you're working off of, and it's very clear the treatment path that you are working on with the client. Because oftentimes for the electronic health records, they will carry over that information. So we as clinicians have to be diligent in making sure we truly review what's going on, and we want to make sure that our treatment plan really works off that diagnosis, so that the client can get appropriate care, and so that the client can feel as though, okay, I know what I'm working towards. Now, to kind of bring both of those together, as you're working with that client in the initial session, again, you've given them that provisional, this is what I believe is going on with you based on what is currently being reported to me, and I've reviewed your clinical chart if it's available to me. However, this is what I'm able to diagnose you with based off the available sources of data. And bringing that together, as you see that client, you want to review what's been going on with them. So let's just say you're seeing them over 3 months or 6 months. As you're seeing them, you're really looking back over your notes on maybe, their sleep patterns that they reported, any mood changes that they've reported, any crises that have occurred. Maybe they've had a Baker Act in the last 6 months that you've been seeing them, their medication compliance. So you're really looking at that and you're going, all right, let me look at this diagnosis and see if this diagnosis truly is the right descriptive label, so to speak, for the symptoms that this client is presenting with. So you're just checking yourself. I don't know that I would tell any clinician that you're always going to be right? The goal is that we're getting it right, but it doesn't mean that we're always going to be right, and that's okay. That is not a negative reflection on you as a therapist or you as a clinician. But I know that comes with time. I always encourage people to spend time in the text. So spend time with your DSM. Don't just use your DSM for when you're trying to establish a diagnosis. It's very important that you spend time in the text, that you spend time reading it. And the reason I say that is because when we, as clinicians, only read to diagnose, we tend to look for what we're already kind of understanding or believing that the client has. But when we spend time really studying the DSM and really studying text as it relates to diagnoses, it kind of helps us to not fall into where we favor diagnoses, right? So we're very familiar with major depressive disorder, so we tend to give that diagnosis a lot, not really going, well, what's a differential diagnosis? And that comes with, again, reading the text, making sure that you're studying it and becoming familiar with diagnoses that you don't typically look for, because you want to make sure that you're considering all other options, and that helps you as a clinician to become stronger, to really enhance your skills when you're looking back over the text. And then also what I'll say is that it's okay for you to go based on the information and the time that I've been seeing this client. Let me sit down with them and talk about what I've been seeing and why I may be changing that diagnosis to fit what I'm really seeing with you. Because again, all our clients are not going to give us everything in that first session, and that's okay too. And I want to use the analogy of when we're going to urgent care, right? We go to urgent care, we tell the doctor what's going on with us, and they're just giving us a diagnosis and treatment based on what they're gathering right then. But if those symptoms do not improve over time, you go back and you say, this is what's going on. And so sometimes the doctor will say, well, based on what you're telling me now and based on this not working, it really seems as though this is your diagnosis. And so let's try something different. And it's no different than behavioral health, right? That can happen for us. And so I want to encourage you all that it is okay to not have it right in that first session. Now, I know some people like to lean towards adjustment disorder as provisional. I want to say that I'm not necessarily a fan of using that as my catch-all provisional, only because the adjustment disorder does require that they are adjusting to something. And there's only a set time frame, 6 months, that you can really give them that diagnosis, right? And so I want to challenge you all that if you're using that, then great, if it is truly appropriate for the client. However, if you put that adjustment disorder in, then you do have to go back and update that diagnosis, because an adjustment disorder is only good for so long. After a while, you may need to consider whether your client has another mood disorder that may be more appropriate for what the client is displaying and the symptoms that they're displaying. And so I think that diagnosing is an ever-evolving thing for us as clinicians. I think that we have to continue to enhance our skills, again, by spending time in the text, by really challenging ourselves and really familiarizing ourselves with the information that is in the DSM. There are standardized tools that can help you try to get as close as possible. So the PHQ-9, if your agency is using that, that helps us decide whether or not there is a depressive disorder that may be present or not. And so you can use standardized tools, but that does not mean that you can't also study the text and get close as possible based on your understanding as well, because those standardized tools may not be effective for the client that you're working with, and doesn't mean that they're going to get it right 100% of the time. So that's all I have for you all today. I want to thank you all for checking in. I want to thank you for watching, spending a little bit of time with me. Let's continue the conversation down in the comments. I am definitely interested in hearing y'all's thoughts on any struggles that you're having in diagnosing, how you've navigated those struggles. What I will say is I always encourage you all to be kind to each other and be open to alternative thoughts and views. So thank you all for joining again. #Supervision Sundays. Please share, like, and follow the business page. Share the video. And again, I'm open to feedback. I will read your comments. I'm going to try to respond to everyone. Again, thank you.